Okay. Good afternoon, everyone. We want to thank you for joining our echo session for today. As mentioned in our last session, due to the ongoing pandemic, we'll leave echo open even during this break. Just to say sincere gratitude to all of our partners joining from the various spoke sites who make the network. We are joined by Monze Mission. We've seen some facilities from Eastern, Southern, Northern Province, Northwestern, and we see colleagues from within UTH. Just a quick recap of last week's echo, where we delved into the admission forms that have been designed for all patients with COVID-19 on admission, and also the monoclonal antibodies. Of course, this is not the solution. The solution still lies in getting as many people vaccinated. Monoclonals are reserved for people who have comorbidities that put them at risk of progression to severe disease, such as obesity, hypertension, diabetes, people over 55 years of age, and people who are immunosuppressed. So these are currently available in the facilities, and they are particularly recommended in populations that are not vaccinated. So today, we will be delving into the memo that was released by the Ministry of Health regarding vaccination, SARS-CoV vaccination for the pediatric population, that is the individuals 12 to 18 years old, and we will also look at issues regarding the booster doses. Our experts for today are Professor Lloyd Mulenga. We also are privileged to have Dr. Mwenechanya, who is part of ZITAC. They give advisory regarding the COVID-19 vaccine. And we have Dr. Mupeta Bobo from the Ministry of Health under the expanded program of immunization. I will ask our IT, Kote, to go ahead and share the slide deck from Professor. As he's doing that, I will ask Dr. Mwenechanya to introduce himself and his role in this process, and then Dr. Mupeta Bobo as we wait for Prof to join. Dr. Mwenechanya.
Thank you very much. I hope I'm audible.
Yes, you are.
You're very clear. You're very clear, Dr. Mwenechanya. Thank you.
Thank you. And good afternoon. And I recognize the presence of all senior colleagues connected on this important call. By way of introduction, I am a consultant pediatrician. I've worked in UTH for several years, and I've dealt a lot with children, and specifically, I've been involved with vaccines. Case in point, the pneumococcal, the introduction of the pneumococcal vaccine around 2011 and 2012. I also have the privilege of serving on the Zambia Immunization Technical Advisory Group, ZITAG. This is an advisory group that provides evidence-based recommendations to the Ministry of Health as regards not only the COVID vaccine, but several other vaccines. We have discussed the rotavirus vaccine, we have discussed a hepatitis B vaccine, we have discussed the typhoid vaccine, and we have several other vaccines that are under discussion. And so this group is composed of epidemiologists, public health specialists, vaccinologists, pediatricians, and all other relevant people that would provide a comprehensive evidence-based recommendation to the ministry. Again, on my head is the heart of the Zambia Pediatric Association. I serve as president. I've overserved, I must say, and so I know that there are elections due, so that may not be the case by the time we're having the next call. And so the reason I mentioned all of that is that I have had the privilege of sitting in several meetings where vaccinations in children are very extensively discussed. And so to this particular call, I will probably just bring very, very brief highlights of where we are sitting and advice as to which direction the country should go. For now, I submit, Chair. Thank you very much.
Thank you so much, Dr. Mwenechanya. Some keywords there. This is evidence-based guidance, so that matters a lot. It's a difficult situation, but we'll deal with the evidence we have on the ground, so that's very important. Dr. Bobo, please go ahead.
Thank you very much, and good afternoon, everyone. My name is Patricia Mpeta-Bobo. I'm a pediatrician as well, currently working as Assistant Director for Child Health and Nutrition in the Ministry of Health. The expanded program on immunization, or EPI, is one of the programs under my unit. Thank you, Chair.
Thank you so much. I believe, Professor, you have a slide deck to share with us. Please go ahead, and then we'll allow our various experts to zero in on the issues. There are many questions, but we'll try to stick to our timeline and end by 4. Professor Lloyd.
Thank you, Dr. Foloshi. And thank you, Dr. Bobo. We are so grateful to also have Dr. Mwenechanya. I would like to just share on the perspective of introducing the booster vaccines in Zambia. And as I do so, I'll highlight even some issues which are prevailing around the booster vaccines globally, and also the justification around this and the approach. We know very well that the immunity which is arisen from COVID-19 infection lasts for months, possibly 3-6 months. And this immunity is systemic in nature, just not looking at the antibody immunity, but also the mucosal immunity as well is enhanced. We also know very well that the vaccine-induced immunity to COVID-19, it also right now does not have any evidence of inducing mucosal immunity. As a result, we do not have that protection from the mucosal immunity, but we also note that those who have a weaker immune system may have delayed response and also low stimulation of the antibody response after the vaccination. What we also really are concerned about is the fact that those that may not have a robust immune response may not respond well. And we highlight as well the importance of vaccinating the priority populations in the booster series as well. However, the main emphasis should be that our concentration should be on giving immunizations to every individual, the primary series, as opposed to concentrating on the booster vaccines. This is what I said with the current COVID-19 vaccines. We do not have any mucosal immunity which is induced. And right now there are developments on nasal COVID-19 vaccines. And for these, possibly they may also lead to protection against severe forms of the disease, and also with mucosal immunity as well being induced as well. Now, we know that the neutralizing antibodies, they do seem to correlate with the protection from symptomatic COVID-19 disease. And as a result, studies have been looking at the levels of the antibodies which are generated and how long they last after vaccination. And for now, we know that at least the protection lasts for 6 months or beyond. But we also have now data of neutralizing antibodies which wane over time, but it's not clear at which level does the protection that does wane as well. And as a result, we have seen a lot of research currently around breakthrough infections, but even as we talk of the breakthrough infections, these are expected in a number of people, in fact, majority of people, but they will have less severe infection as opposed to those who are unvaccinated. We also, when it comes to breakthrough infections, WHO has not issued any guidance on the booster vaccines, if we should be able to give them. But we know what is important is the emphasis on equitable availability of vaccines to all vulnerable populations. We have evidence currently of increased immunity with booster vaccines, and also if you mix the vaccines, there's further enhancement of the immunity. But as I said, due to limited vaccines, our emphasis should be on really having the primary series of vaccines given to all individuals. And remember, we have a target of having 70% of our population covered by June next year. We are concerned, of course, of various reports, but even including the data which we have locally as well, those that are immunocompromised, they may not sufficiently have enough response. It's been seen for organ transplants recipients, 4% in one study did generate the antibodies, and 40% after the second dose, and 68% after 3 doses. So again, you see that there's a subsequent increase in immune response with increased doses. We have this report, and this is not a peer-reviewed article yet, on the effectiveness of the vaccines against the Omicron variant. And you can appreciate this when you look at the dotted black slides. The black one are looking at those that were given Pfizer. Then the gray one, it's looking at the vaccine. The black one is for the Delta. Then the black one is for the Omicron. The gray one is for the Omicron. So you can see that over time, once a booster is given, you see that with the first one, which is looking at the AstraZeneca, even when you give the Pfizer, you have an increase in the protection, even against the Omicron, which was really, really low before the booster. And similarly, again, if you gave those that had received 2 doses of Pfizer, again, the protection did go down with the Omicron variant. But once a booster is given, you see the protection levels going higher than 80 into 90, above 90%. Again, emphasizing the need for boosting in certain populations. Breakthrough infections, again, overall, there are reports which have reported about 1 in 5,000 individuals who've been vaccinated, they will get the breakthrough infections. And more recent data is showing about 1 in 100 fully vaccinated people. And when you look at our scenario here in Zambia, currently we have about 12 to 16% of individuals who are hospitalized have been vaccinated. And meaning that even here, we are having breakthrough infections. This is just looking at the share of infections with the dotted, with the lines under blue, they're showing those with breakthrough infections as opposed to those who are not vaccinated. Again, you can see then that we have up to about 20–30% of individuals would have the breakthrough infections, and this is the data from the US. Again, you see the differences in the age, more female, more male, but again, this is because more female are vaccinated generally in the US, and this is our trend as well. We are seeing now more females. Instead of in terms of the age group, again, those that are highly affected, the 50 to 64, a majority, the 35 to 49 as well, but the young ones as well are affected. Then of course the 80 plus, again, this is a smaller population. So you see that the breakthrough infections, they occur across both gender and also across the age as well. This is what I said, where the WHO now concentrating on giving vaccines the primary series of vaccines. And this is also our focus as a country. We should focus more on the first series of vaccines. However, we need to protect those that need to be protected. Let me just look at the data from Pfizer, looking at the efficacy and safety after boosting. And this is just a 2-month interim analysis. This included about 10,000 participants from the age of 16. And these were compared, those who were on a placebo compared to those who received the booster. I wanted to also highlight the issues which have been coming out of the side effects. So you see, we have the local reactions, injection site pain 0.7%, 0.3%, site readiness, nothing in this, then injection site swelling 0.3%. Again, these are very, very small numbers of those that did experience side effects. Generally, someone having systemic events about 5.9%, with the common one being some fatigue after being injected, then also followed by the muscle aches or muscle pains about 1.4%, chills, headaches. And these are the same side effects which you've been seeing even across the vaccines which you've been giving as the primary series. When you look at the effectiveness, again, I won't go into much detail, but this is just looking at the effectiveness. You see that the relative vaccine efficacy goes up to 95.3%. This is 7 days after the booster vaccination to less than 2 months after the booster vaccination. Again, showing some relative good vaccine efficacy. Now, when you look at those who had with or without evidence of infection before the 7 days, prior to the second dose, because there you have the mix of individuals who have had infection, you see that it lowers to 94.6%. Again, showing some good vaccine efficacy. This slide is showing us how the incidence of new infections are occurring for the all available population. And you can see that the red one is seeing those who are placebo, then the blue one is for those that were given this Pfizer booster. And you can see clearly the evidence is there of the difference between the red and blue. You can see there is wide difference of the number of infections. Each dot reflecting when you have an incident case or when you have a new infection. Very, very few infections for those that were given the booster dose. There were reports of hospitalizations and those did not have even any severe disease. When you look at the age again, you see major differences, minor differences in terms of those who are 16 to 55 and above 55, with effectiveness ranging 93% for the above 55 and 96% for 16 to 55. In terms of gender, again, these are comparable, not really much difference in terms of the viral efficacy. Again, in terms of the race, the white 95, black population 100, and then so really you cannot pick much among these, the ethnicity and also the race in terms of the effectiveness. So this really did confirm that there is high relative efficacy in those people that are boosted compared to those who are not boosted. And this is from 7 days to 2 months after the booster. The adverse events which are reported, again, they were mild adverse events, relatively comparing to what we see even in our situation. So what are the priority populations? The individual who may have hematological immune malignancies, those with primary immunodeficiency disorders, HIV infected. Then we also have some individuals who may be receiving immunosuppressants, steroids, immune modulators, those who are on dialysis. And we also are included as healthcare workers among those who have at risk of higher severe disease, and therefore we need to be vaccinated with a booster vaccine. Then above 55 years, then those with comorbidities like diabetes, hypertension, and kidney disease. We have these recommendations for tier 1 healthcare workers, then the elderly and those with underlying illnesses. In the tier 2, then also tier 3, all those who are willing to receive the booster dose. Now, this we know that we did not do very well when we just started the vaccine, and we are not going to tell anyone who comes to the facility requesting the booster vaccine as long as we have it. These are the recommendations we have. Those that had AstraZeneca, 6 months later, they can get Pfizer, Moderna, or AstraZeneca if the other two are not available. Then those that are J&J, we can use Pfizer, Moderna, or J&J itself, but this should be 2 months after the initial dose. Those that had Pfizer can go on with Pfizer or Moderna, and then those that are Moderna can use Pfizer or Moderna. Then Sinopharm, Pfizer or Moderna can be used, and Sinopharm as well can be used as the third dose to be given. This is really just a summary of where we are so far with the guidance we are giving. And Dr. Foloshi, I would hand over back to you for my colleagues to continue with the presentations. Thank you so much.
Professor Lloyd, thank you very much. I'll allow for some questions before I allow Dr. Mwenechanya to talk about the vaccine recommendations for the pediatric, for the children. Kote, please unmute anyone who has questions. I see we have a question. Kote, please unmute.
Hello.
Yes, Mr. Mulenga, please go ahead.
Yes. Good afternoon, and thank you for organizing the presentation. Of course, I think this data is quite convincing of the boosters that we have. I have just a question, probably it's a premature question, in the sense that I would have loved to see local data showing how we are performing in terms of response to vaccines. Is there a likelihood that we have local data to explain the situation locally? Number two, if not, do we have plans to really take random samples of people we are vaccinating to see the responses for all the vaccines that we are giving? For now, that's my question. Thank you.
Thank you so much for that. I'll allow another question in the interest of time. Kote, please unmute the speaker for the next question.
Good afternoon, Madam
Dr.
Sombo. Good
Yes,
afternoon. Are you able to get me?
Yes, we can hear you very well.
Okay, thank you very much. Very nice presentation, Professor Mulenga, quite enlightening. I just wanted to find out, when we started the vaccination program, there was the issue of us not mixing the vaccines. For example, the person who got AstraZeneca, they should not be given the Johnson & Johnson, and as why, just like someone who has gotten the Johnson & Johnson should not be given another vaccine. In our case, what has really changed with these boosters, where we are saying someone with AstraZeneca, who got AstraZeneca, can actually get Moderna or the Pfizer? Thank you.
Thank you so much. I'm sure people have noted that question. We'll take one more question from Dr. Makelele, Patrick. Patrick Makelele, please go ahead with the contribution.
Okay. My question is on the, hello?
Yes.
My question is on the commodity. I'm talking about the experience in the Eastern Province, basically in Katete, Kasenengwa area. From the field, we are hearing that the commodity is not enough. And there is a fear of the people giving the second dose. Hence, people choosing the vaccine with 1 dose only, where it's like J&J, where it's just giving 1 dose. What measure has the country put in place to reassure the frontliners that what we are doing, commodity management, is secure? Over.
Thank you so much. I'll let Dr. Bobo take the last question on the supply chain. Professor, do you want to address the question on vaccine effectiveness studies and why we are now allowing a mix and match in our policy? Thank you.
Thank you for those 2 questions. So yes, we have developed data, and I think I did allude to the fact that right now we have 12 to 16% of those that are admitted, they've been vaccinated, and it's across all vaccines. We have seen admissions for people that have gotten Moderna, Pfizer, Sinopharm, AstraZeneca, J&J. And just to let you know that we started collecting this local data immediately we had the vaccines available. Let me refer to the 3rd wave. In the 3rd wave, we had 9,893 admissions where we collected the data. And with that, we had 1,883 deaths. Again, when you look at the deaths, only 3.8% of those deaths, they had at least 1 vaccine given to those that we lost. We never lost anyone who was fully vaccinated. In fact, we only had 2 who were fully vaccinated, who were admitted, but we never were giving a percentage of 0.1%. The median age again was 54, 55 for those that were getting the breakthrough infections. Again, similar to the data from the US. So yes, we have local data, then we have a robust vaccine effectiveness study. And we'll be also looking at, there's a side that is also looking at the immunogenicity to various vaccines, but this data is not available for sharing yet. So we have local data, and there are more platforms where we're collecting information related to vaccines. The issue of mixing of vaccines, I'm sure you've seen that we are very cautious when we try to bring in certain policy changes. We did not have data to show that if you mix vaccines, what would be the effects in terms of side effects and also immunogenicity as well, how will it be? And right now we have data, as I did present. You see, when you look at those that were mixed, when you compare the Pfizer given to those that were exposed to who had AstraZeneca, the response was better when there was using the vector initially, then you move to the messenger RNA-based vaccine. It was this type of studies which really led to us saying that we can mix the vaccines. So our policy change is based on the data, and I'm sure my colleagues, Dr. Bobo, Dr. Mwenechanya, they also attest the fact that if we see that there's something better, I think as a country, there won't be delay in trying to implement as long as we have data to suggest the same. Thank you, Dr. Foloshi.
Dr. Bobo.
Thank you very much, Dr. Foloshi. I just want to say that, I mean, that's in response to Dr. Makelele's question about commodity security. So currently in the country, we are receiving the vaccines through 3 main channels. So the first one is a mechanism called COVAX, which is which is made up of a number of organizations, including WHO. And we are getting these vaccines for free. That is, the country is not paying. And from the outset, they had pledged to give us up to 20% of the eligible population's requirements. So that is the COVAX mechanism. The second channel is through what is called the African Vaccine Acquisition Trust, or AVAT, which is under the African Union. And we are actually paying for vaccines through this mechanism. And then the last channel is through donations. So when we started the vaccination exercise, we had come up with a national COVID-19 vaccination deployment plan. And we based, that time we're looking at the eligible population being all persons 18 years and above. And roughly these constitute about 8.4 million, which is about 46% of our population as a country. So from the outset, 20% of these, which is approximately 3.7 million, were supposed to be covered by the COVAX mechanism, the first mechanism I alluded to, whereas the remaining were supposed to be catered for under the AVAT, as well as the donations. But that time when we were actually coming up with a plan, we didn't talk about donations. It was basically the two mechanisms that we were focusing on. And of course, now that we've added the other age group, the 12 to 18, who also comprise about 3.7 million, that is a different story. But suffice to say that we've so far received about 4.8 million doses of vaccines in country, and we've distributed to the subnational levels about 3.2 million doses, and we still have a balance of about 1.3 million here at national level as I speak. But the main thing to remember is that these vaccines keep on coming, and the most important thing that is driving our receipt of vaccines, more vaccines, is the demand, So as long as we keep on consuming vaccines, it means that we're going to create enough room, even in our storage facilities, to get more vaccines. So right now, there's no shortage of vaccines. We haven't heard of any shortages at subnational level. Of course, there will be a few issues of distribution at certain levels, but generally we have enough vaccines and people shouldn't panic. What is supposed to happen is that every time people run out of vaccines, they know the channels through which they're supposed to get more. And we are also on standby so that we can deploy more vaccines to the areas of need. The other thing that I must mention, because you talked about J&J, there's this preference or seemingly preference of J&J by a lot of people. And I think it's easy to understand because it's, right now we are only giving it as, one single dose. But at national level, because we have a lot of vaccines, we have currently 5 vaccines. We are trying to encourage consumption of whatever vaccine is available. So we are changing our language as, as a unit. We're just trying to look at them as COVID-19 vaccines. And we have a criteria that we use when you're distributing vaccines so that at the end of the day, all the vaccines are consumed. So Dr. Makelele, if you know of any place, like you talked about Lumezi, I think the provincial health directors, we are always in touch. There should be something going on, and I'm sure it's going to be rectified. Otherwise, the vaccines are there. Thank you, Dr. Kolosh.
Thank you so much. We have a lot of questions, but I really want to give Dr. Mwenechanya room to talk about the current recommendations for vaccines for individuals aged 12 to 18 years old. Dr. Mwenechanya.
Hello, can you see my screen?
Yes, we can.
Okay, so thank you very much. I think I made the introduction, probably for those that were not on it. I introduced myself as a consultant pediatrician, as well as someone who is privileged to sit on the Zambia Immunization Technical Advisory Group, which is a ZITAG that provides evidence-based recommendations to the Ministry of Health on vaccinations. And I happen to be privileged to be the president of the Zambia Pediatric Association. So the outline of my presentation, very brief presentation, I must say, is that I'll just give a very brief background as to what is happening around the globe in terms of vaccinations in children, what scientific advances have happened as a result of that, and how other countries have responded, some of the issues that have come up as a result of the vaccination, and then try to domesticate all those issues to our scenario in Zambia, and what sort of challenges we anticipate. And then, of course, I'll try and conclude with what we recommended as a technical group. So the issue is what was the thinking? Why was there a shift in thinking? So I think that originally, when we look at the first and second waves, this was a disease that was predominantly in adults. Adults were getting severe disease, hospitalizations, and so on. And I think as the waves were progressing, this was getting more and more severe. However, it was noticeable, particularly in the third wave, that the one affected, that Delta was predominant. We saw a shift in that age group, lower down. And we started seeing quite a number of adolescents. And I think this is the case. I'm sure ZNPHI can give the actual statistics, but I think we all know that we saw a change in demographic. Younger and younger individuals were affected. And this is what really prompted scientists and whoever who was monitoring what was going on to start the discussion around how do we protect children. It was also not clear what the role of asymptomatic spread had, particularly in schools and also in other areas where children are known to interact. And we also started seeing mortalities in a younger age group. So this sort of prompted scientists to start thinking around dropping the age for vaccination. So the question is, why children?
I'm sorry, Dr. Mwenechanya, is it possible for you to change the slides to presentation view? We're receiving some complaints about it not being visible.
Right. I've changed to that view. Is that better?
No, to put it into presentation view. It was on presenter view.
I see.
So you could just click on swap displays on the top there.
Right. A second. I'm using two screens, so that's a bit, okay, just.
Yes, that's great.
That's better, thank you. Okay, so the question was why children? So it's a known fact that children are not as affected as adults, but there is clear evidence that children do get severe disease, do get hospitalized. And around the time that the thinking around protecting children began, there was a phenomenon called multisystemic inflammatory syndrome, MISC, which was affecting children quite severely, affecting several organs in the body. And we do, I think even UTH, we did have a suspected case of such. And I think we worked around this with Dr. Mpeta and team. And so you can imagine this was obviously much well documented in other settings. And this was sort of the driver towards thinking, how do we protect our children? There was also issues around children developing both short and long-term complications of COVID. We all need to remember that all of this was happening in the background of uncertainty. This was work in progress. And so no one was really an expert in all of this at the time. But what was clear was that children were getting affected. And so we needed to find a way of protecting them. Children were also, it was clear that they were spreading this infection amongst themselves, in schools to their teachers, but also taking these infections home and giving them to their parents, grandparents, and so on, because of the nature of the interaction. And so there was a clear role that children, adolescents rather, were playing in the spread of this infection. And there is some evidence that in resource-poor settings, because of our poor, access to healthcare and so on, that children, they are more vulnerable, they have more diseases, more immune suppression issues, and therefore making them at risk. And so the general thinking then was, how then can we better protect children? So the real issue is, what role would vaccination play? There is evidence coming out of Johns Hopkins University, and we all know that's a renowned university for high-level research. And they've done a lot of work to look at transmission amongst adolescents and children in schools. And there's some evidence to show that if vaccines are given to the adolescent age group, it helps them, it helps to reduce the spread of the virus. And that reduction has a ripple effect in also reducing on mutations. Mutations of the virus rely on transmission. And so once we have more transmission, then we have more variants emerging. And so there's a thinking that if these vaccines are introduced in this age group, we can cut down on that transmission and therefore cut down on the emergence of new variants. And then, of course, it feeds into the larger ideology of herd immunity. So what are the scientific advances? So we know that most of the vaccines that are on the market are approved in adults above 18. But very recently, there has been an emergency use authorization of mRNA vaccines, particularly. I think this is for Pfizer and Moderna. And these have been authorized in the age groups of 12 to 17. And this was according to the WHO statement of November 2021. Indeed, there has been also some authorization in some countries, very, very stringent regulation that authorizes the use of mRNA vaccines in as low as 5 years old. And there are trials going on in China where they're giving the vaccine as low as 3 years old. So a lot of work is going on. However, I must say that these are not yet authorized fully by the WHO. Going to India, India has also got a vaccine that is not yet fully authorized by WHO and is also being given to children between 12 and 17. And they have other novel vaccines that are right now work in progress. And one is also being tried in clinical trials to as low as 6 months of age. The results of this have not yet been published. And I think that most of us are very, very keen to see what those results are. And so obviously, once those are released, we should be able to share this work. So how did the globe respond to this? So several of our countries abroad, I think we all know, have achieved vaccination of the primary series in the target age group between above 18 years old. And we are talking about ranges of 70, 80%. For example, in South Korea, which has served as quite a very good example, they've vaccinated about 78.8% of their population. And because of this recent introduction in vaccinating in the 12 to 17-year-olds, they vaccinated about 12.8%. As a result of that, they've been able to open schools fully. And of course, I mean, vaccination is just one thing. They have still managed to, in addition to vaccination, improve on their social distancing and all the other 5 golden rules that we're all aware of. And so vaccination is obviously feeding into the bigger 5 golden rule procedures. So South Korea is a shining example of how this can be done. Why the emphasis on this? I think my bias as a pediatrician will tell you that every child's development is actually dependent on their right to go to school. And I think that we've had several lockdowns globally, And even locally, we've closed down our schools several times. This particular time we closed because it was a calendar. Not clear what would have happened if school was in session and we had Omicron. Would have had several difficulties trying to make decisions as to what should happen in the schools. We must say that COVID-19 has led to the most catastrophic disruption in education in history. And I think that when we look at education and development of children, when we look 5 years down the line, I think we are going to be faced with another pandemic of reduced education amongst our children. We also must think about in our environment, when we are talking about home learning, online learning, the access of our children to some of the things like computers, internet, enough electricity. I wouldn't want to go too deep into that, but I think we all know that it's cheaper and safer to keep our children in school, and vaccination seems to play a big role in that. And South Korea is one such example. In Europe, August 2021, there was a call to keep schools open. And this was at a time when they were facing the Delta variant, which I think we all know has been the most catastrophic amongst all of them. But there was still a push to try and keep children in school because of the long-term effects of keeping them out of school. So the natural question again is, what are the side effects of giving this vaccine to children? This is very much like any other vaccine. And I must say there's not one vaccine in this world without side effects. So the commonest is obviously pain at the site where the shot is given, but we have the other common side effects of headache, chills, muscle pain, fever, joint pains, and in some cases, we've had a bit of lymphadenopathy. But I think that what has been much discussed and caused quite some in many people is the occurrence of pericarditis and myocarditis. So just to say a bit about that, it was observed in a number of children within a week of the second dose of the vaccine by teams that were monitoring the vaccine exercise, that a number of adolescents and young adult males were presenting with chest pain, shortness of breath, and palpitations. And these were followed up through medical records, in-depth history, and so on and so forth. And they were followed right through after their treatment. And what happened was the conclusion, the short story of that was that it was concluded that this is a rare, mild, and short in nature episode. And therefore, when the balance between getting COVID infection, the natural infection, versus giving the vaccine and getting this rare occurrence of the side effect, WHO and CDC gave the go-ahead to continue to vaccinate with the mRNA vaccine. So what's happening in Zambia? So what I'll give you here is really just an overview, so that the world is encouraged to think globally but act locally. I think this is a famous quote. So we have things that are going on, but the last thing we want to do is copy and paste a scenario. So we are in Zambia. So where are we now? We've vaccinated between 10 to 15 of our target population, those above 18. And so the priority, even as we sat as experts, the priority remains to increase that percentage. And we've heard from Professor Mulenga, and this is a national goal, that at least by August, we should be able to hit that at 70%. We all agree that there's been great political will, including from the highest office. There was a relaunch of the vaccination exercise. And as a result of that, we saw an increase in the number of people being vaccinated. That political will has extended to the kinds of appointments that have been made. And now we have a COVID advisor to the head of state, who I think, if we've been following with Dr. Bobo, has been going around the country, visiting churches and so many other places, trying to increase that percentage. This effort should be encouraged, enhanced, and I think we all have a role to play in trying to increase that percentage. We also know that despite that, we have a low uptake of this vaccine, especially amongst healthcare workers, the elderly, and also people with comorbidities. These were the target groups that we identified that should receive the primary series vaccine. So we have a lot of work to do there, and a lot of questions have come up. So if you say you're going to give it to children, these are children of the same target group that didn't want to get the vaccine. What's the guarantee that children will receive the vaccine? Well, this is the role of the health promotions. We need to disseminate this information on the importance of receiving this vaccine. Remember, at the end of the day, the balance is really between getting COVID-19 infection or getting the vaccine. I think that once one makes that balance, the decision is made easier. We do know that we have several vaccines, and Dr. Bobo has added figures to that. So we do know that we have vaccines in country, and we are expecting more vaccines. So when we tie up the vaccine supply in the country with what the uptake has been versus the demand, because we do know that there are individuals who will wake up and say, I want that vaccine and I want my children to receive the vaccine. So when we start putting in equity issues and ensuring that we don't have a disruption in supply, the current situation is we have vaccines, we have people who don't want the vaccine, and a lot of work needs to be done there. But we also have a cohort of people who want to get this vaccine. And every person who receives the vaccine contributes to that protection, contributes to increasing that 10 to 15 to 70, and therefore they should be offered. I've already spoken about the home learning scenario. So the challenges, like I've already said, is really the uptake. We have a lot of work to do in terms of ensuring that we increase the number of people in our target group being vaccinated. We have an issue of information dissemination, learning from previous experiences. The nurses or whoever is assigned to give these vaccinations need to be fully equipped with information. Also, they need to be equipped with methods of recording immediate reactions to vaccines. Having sat in some of these high level meetings where we are discussing just science, you actually find that all the science they are discussing is being generated by countries that have decided to record each and every event that goes on around vaccines. And they have robust databases that are following up these recipients. And I heard from the call, are we doing anything to see what's happening to the antibodies and responses? The decision for the booster dose, for example, came as a result of individuals who received both doses of say, AstraZeneca in our case, and were followed up, and they demonstrated a drop in antibody titers. So we can't do that unless we are actually following. I know that Professor Mulenga and team are trying to strengthen those areas. And so from a vaccine site perspective, we need to ensure that we have all our records in place, and the recipients of these vaccines must know where to go and how to have their symptoms and their symptoms recorded. And I know ZNPHI has put in measures, but I think that we need to strengthen this. The issues of cold chain, I think that I can leave to the ministry, but just to emphasize that Pfizer comes with quite some stringent issues to do with preservation of temperature. It's minus 70, so that cold chain needs to be managed very well. And that in itself introduces inequities, considering how many areas in this country we can actually distribute this to. And then of course, pilferage. I think this is an issue that we should not overlook. It's quite rampant. So what is the conclusion? The conclusion is that no one is safe until everyone is safe. I think we should understand this concept very well. We want to protect ourselves, and part of that could just be protecting children as well. Again, we speak not with 100% certainty, but at least with some of the evidence that is there. No one is a true expert in COVID because this is an evolving situation. However, we must be as dynamic as the virus itself in how we approach some of these issues. Of course, the 5 golden rules play a role, and vaccination just adds on to that. I've already spoken about continuous public education. We have seen our Minister of Health going into the markets, into the bus stations. That helps to boost our percentage. So this needs to continue at that very high level. Again, data I cannot overemphasize. We need a robust system of collecting our symptomatology from recipients of the vaccine. We need to look at what circulating variants are coming out. We need to have a systematic way of recording our side effects, both immediate and long-term. This database will help experts as we provide evidence-based decisions, because it will be locally generated data, and it will really, really go a long way in helping our own. I think the take-home message is we must focus on the primary series. We must increase that percentage to 70%. I thank you. Chair, I submit.
Thank you so much, Dr. Mwenechanya. I think those points are very clear. There is a lot of questions. We'll start with Modest Mulenga because they have their hand up. Modest, please go ahead with your question, and then we'll allow Roy Dazulu to ask her question. Modest, go ahead.
Yes, thank you very much. Again, I'm Professor Mulenga as well, from Lusaka Apex Medical University. Thank you very much, colleagues, for a very lucid account of what you are doing and the decisions that are coming from the data. I can't emphasize much the need for local data to do so. We are gravitating to children. I would also love to see if there is a particular group of children who are particularly vulnerable to COVID-19 or who are vulnerable to hospitalization or death. Is it the malnourished? Is it the overnourished? Is it those with other comorbidities, particularly children? We need to know so that that can also be emphasized. I also note that you see, the resistance by health workers is a very dangerous thing, actually, when they are supposed to be in the lead. To me, it indicates that an average health worker has been left behind in understanding this complex disease. Continuous professional development, in my view, is very, very cardinal, and we need to have innovations as to how we educate our fellow health workers so that they become our emissary to see how we attack this disease. If we don't do so, I'm sure we are going to be meeting resistance because they are the ones going to be misinforming people. And indeed, those have been the sources of misinformation to the public. Thank you.
Thank you, Professor Mulenga. Professor Dorothy Chanda, do you want to ask your question? Okay, so we'll allow Dr. Mwenechanya to go ahead and address those concerns. Dr. Mwenechanya.
Yes, thank you very much. If I got the question correctly, the issue was, since we are gravitating to children, who exactly should we be looking at? Is it the malnourished children and so on and so forth? I think that's what I picked up. So I must say from the outset that, again, it remains mild disease in the majority of children. So, and this is a global phenomenon. So children are not at risk of severe disease and hospitalization as adults. However, there are children who are at risk, and some of those fall similar to the adults. I think the main issue of interest here would be a child with heart disease who then requires to get Pfizer, because there's been issues around one having a heart problem and they need to have a vaccine. Remembering that if that child with heart disease gets COVID, they are more likely to have severe disease and hospitalization. Since there are several heart diseases in children, the recommendation is that a very intense discussion needs to happen between the caregiver and that child and the attending cardiologist before a decision to give that vaccine is given. However, to answer your question in general terms, we haven't seen a very dramatic rise in the number of patients who, for example, who have malnutrition, who then develop COVID severe disease. We do, however, see lots of children developing mild to moderate disease, but not as bad as we see it in adults. So I hope I've covered your question. Again, it speaks to the fact that we need to document. There's a lot of information that we haven't documented. And so, as you can imagine, most poor resource settings are pretty much the same. So this provides a great opportunity for us to start recording some of this information, for us to speak with much more confidence about who is at risk. The drive was also towards trying to see the role of prevention of transmission and mutation, emergence and things like that. Chair, I submit.
Hello, Chair. I'm ready with my question.
Please go ahead.
Okay, thank you very much, Dr. Mwenechanya and Professor Mulenga, for your presentations. I have one very cardinal question to ask for clarification, and that is, please clarify on the fact that people are saying that the vaccines can alter the immune system. I think that's where the problem of acceptance of the vaccine lies. Are the vaccines able to alter the immune system? Thank you. I submit.
Professor Lloyd, do you want to take that one?
Yes, thank you, Dr. Chanda. I hope you are well.
Yes, I am. Thank you.
Thank you. We really have a lot of issues surrounding vaccines and a lot of myths as well. So far, what we know is the immunity which is there is just enhanced immunity because you have generation of those antibodies, and I think Dr. Mwenechanya went into that as well. So there is no alteration to any specific immunity someone may have had against various agents. And also there is no interaction with any other vaccines which have been given in terms of the antibodies towards certain specific antigens as well. So far, we have no indication that there is any alteration in the immunity. And this includes also the messenger RNA vaccines. Those are the ones which were also feared because they lead to just production of the proteins, which lead to enhancement of the immunity, not really any change or alteration in the immune responses which are there before. Thank you.
Okay, maybe I need to be specific. I think that the specificity is on the DNA.
No, there's, as I said, Doctor, that was, I think, one of the main fears when people thought that there was we are given the RNA vaccines. Now, what these are doing is just leading for the body to generate the proteins themselves. So there is no incorporation of this RNA into the genome, the human genome. And that was where I think many people were concerned.
Yes. Okay, thank you very much indeed for that clarification, Professor. Thanks.
So, Professor, there are some questions regarding the booster shots. The first question is, for the booster shots, is it 1 or 2 doses as well? I think this is the $1 million question actually that is linked to another question, but there are so many, I think I've lost it. But they're asking, is it going to be only 1 booster or is it 2 doses? How many doses should we anticipate of booster?
Yeah, so far it's just a 1 dose given at different time points. And I don't know if it's today or I didn't mention or yesterday, that we need to be aware that for the COVID, there is a lot that we are yet to learn. So should there be data showing that even after this booster dose, there may be need for other doses, again, that will be decided based on the data. Remember, we just going into a year of vaccines, and we don't have much experience globally. So there'll be a lot of things that we'll need to learn. And as long as data shows that you can enhance protection by giving further doses, then decisions are to be made. And thankfully here, we have a very active ZITAG, the body which Dr. Mwenechanya was referring to, and it has technical leadership as well. So it looks at the data, not just local data, international data, and they have a good grasp of understanding vaccines. So we will get what will prevail at that time, and the policy changes will be based on various recommendations. Thank you.
Thank you so much, Professor. So for now, it's one booster because we are depending on affinity matured antibodies. So we are trying to trick the immune system into doing a better job, and we are hoping this is more effective at recognizing variants with multiple mutations, but with time, this data can change. So for now, it's one booster. Thank you very much, Professor. There's a question that is almost making me shed a tear here. And I think this one will leave to Dr. Mwenechanya as coming from Zaitag. That's how that's pronounced. Dr. Mwenechanya, should pregnant women receive the vaccine? I know we had a long session on pregnant and breastfeeding, and Zaitag did give guidance, but do you want to answer this one? Should pregnant women get the COVID-19 vaccine?
Yes, so thank you very much. So after extensive review, and I think one may just even refer to the CDC website, once one is given any of these vaccines, it was actually shown that there was very little that crossed the placenta, and even for breastfeeding mothers, the issue was it was not demonstrated in breast milk. And I think that for pregnant mothers, it was even, the drive was even more, because I'm not an obstetrician, but I think from the pathophysiology has been shown that when a pregnant woman gets COVID, she's likely to get severe disease. And so they need to be protected. I think at the time we're reviewing, it was now an issue of trimesters and so on and so forth. But the general guidance is pregnant women should receive the vaccine. If they then have comorbidities or any other contraindication, the recommendation is that they then have a discussion with the attending OB and a decision is made. But pregnant women are at risk of severe disease and therefore they need to be protected. I submit, Chair.
Very nice summary. So, Professor, with regard to the epidemiology and the stats, what have we seen among the pregnant women in terms of admission, and what sort of pregnant women are we admitting and hospitalizing? How's our data looking?
Dr. Foloshi, in fact, we haven't seen as many admissions for the pregnant women than what we are seeing now in this current wave. I'm sure you can remember Levy was overburdened, and now UTH. The levels of infection we are seeing among children and also the pregnant women are unprecedented over all these, the 4 waves. We are seeing young women and no comorbidities as well. But I need to raise that we lost a lot of pregnant women in the last wave who had COVID. And it's gratifying to see that now we are seeing even, we are seeing women reporting early, and we're able to give interventions, including monoclonal antibodies. It's the younger age group which are suffering. Fortunately, so far, we have only, in this wave, we have only lost 1 pregnant woman on the copper belt. Thank you.
Thank you. So hence emphasizing the importance of vaccinating the pregnant and breastfeeding. There is a question on the rationale. Why are we getting J&J after 2 months, while the other concerns about the cold chain? There are a lot of questions regarding that. Professor Lloyd, why J&J?
I may have missed you, Dr. Foloshi, but I think the question is around J&J, the 2 months, then whereas the others are 6 months. A small study, the J&J, and showed that for 6 months, before 6 months, average the vaccine, there was some reduction in the titer levels. And so there was need for consideration of giving the booster earlier. We are yet to see if this is going to hold for the Omicron and for how long. So that recommendation, both CDC and our local recommendation, the European agency recommendation as well, is based on a few smaller studies and also observations. Thank you, Dr. Foroshi.
Dr. Bobo, would you like to address the cold chain issues regarding Pfizer and Moderna? People also want to know, is Pfizer and Moderna available across the country, or is it just a Lusaka vaccine?
Okay, thank you very much. I'll start with the Moderna. So far, we've received very few doses of Moderna. And in our plan, we always come up with a distribution plan. And almost all the Moderna that we had received have gone to local province. And I must add that the uptake has been very impressive. For Moderna, I'm sure people know that you can keep it, the requirements for cold chain is between -25 degrees Celsius to -15 degrees Celsius. And after that, you can increase the temperature to between 2 to +8 degrees Celsius. And it can stay in this state for up to a month. So Moderna is generally easier to manage based on this, because when you look at the cold chain that we have in the country, I mean, the freezers that we have around the country, most are actually able to maintain these temperatures that I've mentioned. And that's why I'm talking about Luapula. Luapula is not Lusaka. So Moderna, because of the limited amounts that we received, we decided to send it to just one location rather than splitting it into different, into smaller quantities. When it comes to Pfizer, unfortunately, we're not so lucky. Pfizer has to be kept between -80 degrees Celsius to -60 degrees Celsius. And the amounts that we've received so far, we can keep them in this state, or like the ones that we have, the vaccines are supposed to expire in June. So they can stay in this state for up to 6-7 months plus. Once you reduce them, once you reduce the temperature to, you can reduce the rather increase the temperature to between -25 to -15 degrees Celsius. And the vaccines can stay in that state for up to 2 weeks. And that is cumulative. So you can decide maybe to keep it between 25 to -15 for maybe 1 week. And you can only take it back to the outer cold chain, which is the, -70 degrees Celsius on average. You can only do that once. And then if you take it out again, you don't again start counting like 1 to another 14 days. No, that is cumulative. So because you had kept it outside for 1 week, you can only keep it now in that particular state for another for 1 more week. After that, it has to be now, the temperature has to be increased to between +2 and +8. And it can stay in that state for up to 1 month. If you keep it between 2 to 8, after 30 days, you have to discard. So that is how we keep Pfizer. So right now, in terms of vaccine outer cold chain, we only got a few fridges that came in, courtesy of UNICEF, and we only have capacity for about 600,000 doses. I must add that we have a number of labs that have outer cold chain, but we are a bit reluctant to mix vaccines and the outer and the lab, because of obvious reasons. We use them for different things. Though we are in talks with, for example, TDRC to see if we can get more storage. Like as I've said, we can only keep a maximum of 600,000 doses in the fridges that we have at the moment. So this is the cold chain that we're talking about countrywide. The reason why we started with Lusaka is for obvious reasons. We are situated in Lusaka and they're using us as backup. So basically we have the vaccines and it's easier for them to come and get them when they need them. Copperbelt was given some doses. And like I've said, we have some arrangements with the TDRC as well. So right now, as we speak, we're trying to come up with, we're trying to see how best we can distribute the Pfizer to all the parts of the country. And like I've said, it means we're going to significantly reduce the expiry date. As I've said, it can only stay in between the 2 to 8 degrees Celsius for a month. Right now, I must also add that the uptake of Pfizer has been very poor, even within Lusaka. Of course, we know that maybe in terms, there are issues with documentation as well. But when you compare the utilization of the uptake of Pfizer right now in Lusaka, we are yet to even reach 500 doses that have been used. Whereas for Moderna, which I talked about, we've almost used up to about 5,000 doses. So there are these things that we're trying to consider. So yes, it's the vaccines are supposed to to be distributed to the rest of the country, especially now that we are talking about boosters, and also the fact that we're going to give children who are less than 18 years old. And when you look at all the vaccines that we have in country, it's only Pfizer that is the one that has been recommended to be given to children. So we are just trying to work out the mechanism, the best way to actually distribute. And I think somebody said, is Lusaka, Zambia, or something like that. It's not, I hope my explanation is clear. It's not about Lusaka being Zambia. It's basically about storage. And it is quite a complicated vaccine. I hope I've tried to explain that. Thank you.
Thank you so much, Dr. Bobo. That sounds quite complicated. We may call upon you as we do another orientation on Pfizer to the rest of the provinces, so that it's clear, particularly that we are giving these children. We have Mr. Cosmas, who has had his hand up for a very long time. Sincere apologies for this. Mr. Cosmas, please go ahead.
Hello.
Yes, please go ahead, Mr. Siluyele.
Yes, madam. My question has been just answered. I wanted to ask about the storages. So, like us who are in a rural health setup, we don't have even power. Are we going to have that access to Pfizer or to those storages which were brought? And we don't have power in rural centers.
Dr. Bobo?
Yeah, thank you very much. I don't know if it's Dr. Cosmas. So I believe that at the moment, even without power, you have a mechanism through which you give routine vaccines, especially in children under 5. So when I talked about temperatures between +2 and 8 degrees Celsius, these are the normal temperatures under which we keep most of the vaccines. So I believe there is a chance you're also going to have access to the vaccines. The only thing, like I said, is that once you reduce the or you increase the temperature to this particular to these temperatures, they can only be kept in that state for a limited period. So it's about all of us working together, health promotion, making sure that we maximize the uptake of the vaccines. Otherwise, we're going to lose a lot of vaccines. And like I tried to explain earlier on, these vaccines are coming from, we are basically dependent on other countries giving us these vaccines, either through the COVAX that I mentioned, or the AVAT, or even indeed donations. So this is where we are. We are just trying to see how best we can do this so that the issue of equity is taken, is taken care of. So it's not our, it's not like we just want to keep vaccines away from the people. We want, we are trying as much as possible to make sure that the vaccines are distributed to all parts of the country. And Chair, if I may, since I'm already on the floor, there's an issue about the card. So right now we don't have any intentions of changing the cards. And when coming to get the booster, you're supposed to actually come with a card. And if you notice on the card, there's provision for other vaccines, and that is where we're going to put the booster vaccine. Thank you, Chair.
Thank you so much, Dr. Bobo. There are quite a number of questions. There's one for the pediatric team. Are there any precautions to take for children with cardiac disease, since those vaccines allowed in children said to have been implicated in pericarditis and myocarditis, even if it is just for a short period? Are there any precautions the healthcare workers should take? Dr. Mwenechanya.
Yes, thank you very much. So I think I alluded to a bit of that. I think the first precaution is if one has a known cardiac disease, I think it's prudent at that point to get an opinion from the attending cardiologist before one is given. However, not everyone will know. And so once the vaccine is given, this is why I think we need to have a very robust way of picking up the common signs and symptoms. So the precaution would be observation. We need to know if one is developing shortness of breath, palpitations and things like that. And then they need to receive the appropriate care. And I think at that point it becomes clinical care. So I think that if those symptoms set in, then there has to be an adequate way of making a referral so that clinical care can happen. I think that is the major precaution. But I think that if one is a known cardiac patient, it becomes easier because that discussion happens before the vaccine is given. I submit, Chair.
Thank you very much. I don't know if there are any more questions. I see 2 hands. Please go ahead and unmute yourself and ask the question. There's a question from Jackson Mwewa and Kefas. Jackson, please go ahead, then we'll allow Kefas.
Yes, Doc. I wanted to find out, as a country, if we have doing any research on the long-term complication of COVID-19 infection, especially those who had the COVID. If any, what complication has been noted so far?
Thanks, Jackson. Kefas, please go ahead.
Still muted. Good afternoon, Doc, and the team. I just want to find out, there are those individuals who are vaccinated with the first dose AstraZeneca, but up to now we haven't received AstraZeneca. It's out of stock, and they are due. They are even a month ahead of the time they are supposed to receive. When are we receiving? And if we are not receiving any, is it possible that they can be vaccinated against with any other vaccine? Thank you.
Thank you, Kefas. Dr. Bobo, would you like to answer that one? Then Prof can answer the post-COVID complications question.
Okay, so I'm not very sure if I got it correctly, but I believe it's about boosters. If people can receive other vaccines, the answer is yes. If you notice from what Professor Lloyd was sharing, there are a number of alternatives depending on what somebody got in the primary series. So, for example, if you got AstraZeneca, you can either get you can either get Pfizer or Moderna, or AstraZeneca itself. Sinopharm, you can get Pfizer, Moderna, or Pfizer or Sinopharm itself. So there are these options, and I believe even right now, despite the logistical problems we have in making sure that all the parts of the country have the Pfizer vaccine, the other vaccines should be available, and people should start getting, depending on when they are due, using the other vaccines. I hope that's I got your question correctly. Thank you, Chair.
Dr. Bobo, can I just add? So I think in addition to what you mentioned, which is the booster, I think his concern was that if one received one dose of AstraZeneca, didn't complete the primary series because of lack of an option, can they then get a different vaccine? And I think the general answer to that is yes. I think from the literature that we reviewed, where there's mixing and matching, particularly in settings where the vaccine supply is low, you can get AstraZeneca as your first dose, and you get Pfizer as your second dose. As a matter of fact, if you give the AstraZeneca as a first dose, the immunity response when you give an mRNA vaccine is even better. And that is the reasoning behind the booster, that the kind of immune response you're going to get when you've got a primary series of AstraZeneca and boost with Pfizer, then you get a better immune response. So I think the short answer to his question is yes, they can get a different vaccine, particularly an mRNA vaccine. Thank you.
Thank you so much for that clarification and that update on mixing and matching. I'm happy to hear that we've allowed that. Dr. Bobo, just a quick one on the cold chain. Is a 30 degrees Celsius fridge sufficient for this? Because I would imagine we want to quickly scale up our consumption of Pfizer because of these children we have all over the country.
Yes, so like I said, when you move it from the outer cold chain, you can actually keep it between -25 to about -15. And most of the fridges that we have across the country have this capacity. The only thing, like I said, you can only keep it at these temperatures for 2 weeks, maximum 2 weeks, after which the temperature has to be increased to the normal 2 to 8, and then you use the vaccine within a month. So I hope that is clear.
Okay, that's very clear. So I think as a country, we should be aiming to rapidly scale up and distribute this vaccine, especially that these children are now on school holidays, so they don't have to miss school because they are ill from the vaccine, isn't it? So the rest of the country should have this available to them. Is that so, Dr. Bobo?
Yeah. So again, in terms of transportation, we do have some issues because we have limited carriers for -25 and -15. So these are some of the logistical problems that I said we are trying to resolve so that we can distribute as soon as possible. But we're working on it.
Thank you so much, Dr. Bobo. That feedback is much appreciated. Professor Lloyd, would you like to talk about the post-acute COVID-19 phenomena and what we are seeing on the ground, the long-term consequences of COVID?
Thank you for that question. Yes, we have rolled out, in fact, the routine care for those individuals who have the post-COVID syndrome. And the major problem that we see most is people coming in with fatigue. And our main worry is that sometimes we have a disconnect between us as healthcare providers and the patients. Because some of the symptoms which they will complain of, they are subjective. Someone comes in complaining of excessive fatigue, and some doctors, and this is globally, where I think that they're just making up symptoms. We see that very frequently. Of concern, of course, are the respiratory complications. We have a number of individuals who, even after 3 months after discharge, 6 months for some of them, they are still on ambulatory oxygen. Another area where we see a lot of complications, again, those individuals who may still been having high D-dimers, they are able to even go on and have, they throw the clothes all over. You can have pulmonary embolism. We've seen a few of those. But the main one, which is really challenging to manage, are those that we are putting on domiciliary oxygen because of the fibrotic lung changes mostly, and especially those that had underlying lung conditions even before they got COVID. We also see a lot of mental issues as well, and that's why addressing the mental aspect, mental health is very key for individuals who have had COVID. We have some, especially those that were sick and were in ICU settings. They present with the post-traumatic syndromes as well. So those are the common ones that we see. Fortunately, the metabolic changes, which are in the acute phase, they do go down after discharge. Dr. Foloshi, maybe you can also highlight a few more which I may have missed of the common syndromes that we are seeing.
Oh, thank you so much, Professor. What we have seen is insomnia. We have seen tachyarrhythmias, unfortunately, and we have seen some pulmonary embolism and DVTs because they remain hypercoagulable for some time. Professor Lloyd, at this point, please allow us to close the session and sincerely thank you, Professor Lloyd, Dr. Mwenechanya, Dr. Bobo, and special thanks to Dr. Sophia Musiska, who put together this team that has really come and explained everything we needed to know. We will be having another session depending on availability of experts to further explain these two issues that are new in our country. So thank you all who have joined this network and made this session a success. Thank you.